Good morning, everybody, and welcome to all of you who've joined us for this online media briefing. I'm Lyndall Byford from the Australian Science Media Centre. Before we begin, I'd like to acknowledge the land that I'm joining you from today is the beautiful lands of the Kaurna people here in Adelaide, and pay my respects to Indigenous elders, past, present, and emerging from wherever you're joining us from all over Australia. Today's briefing is embargoed until a minute past midnight Australian Eastern Standard Time tomorrow, Wednesday, the 7th of May, because some of the authors have some of the presenters have some new data to present. So we've embargoed it until tomorrow. And this morning's briefing is really just looking at how we are tracking with flu this year. There have already been over 63,000 cases of flu reported in 2025, which is above the 5-year seasonal average. But does that mean we are in for a really bad season, or is it just too early to tell and we really could go anywhere this year? Joining us today, we have 3 speakers. Our first speaker is Professor Patrick Redding, who is the director of the WHO Collaborating Centre for Reference and Research on Influenza at the Peter Doherty Institute for Infection and Immunity. After Patrick, we will hear from Professor Paul Griffin, who is the Director of Infectious Diseases at Mater Health Services and an Associate Professor of Medicine at the University of Queensland. And finally, we'll hear from Professor Julie Leask, a Professor of Public Health at the University of Sydney's Infectious Diseases Institute and a visiting Professorial Fellow at the National Centre for Immunisation Research and Surveillance. As always with our briefings, there's an opportunity to ask our speakers questions at the end of their presentations, but if you think of it at any time while they're speaking, you can pop it into the Q&A box. And please remember to include your affiliation along with your question. You can also ask a question directly if you'd prefer, and you can just raise your virtual hand and we'll unmute you when it comes to the Q&A session. I don't think we have anyone who's just joined us over the phone, but if you have, you can ask a question by raising your hand by pressing *9 on your dial pad, and that will raise your hand and we'll unmute you. So that's it from me this morning. I will hand over to Patrick.
Okay, thank you very much. I'm just going to share some slides. Almost there. Okay, so yes, hello everyone. As mentioned, I'm the director of the WHO Collaborating Centre for Reference and Research on Influenza in Melbourne. We're housed in the Peter Doherty Institute for Infection and Immunity, and we're one of 5 WHO centres for influenza around the world. We analyse and monitor the viruses in detail, and I'm going to talk a little bit about the viruses themselves today. So, Influenza A and Influenza B viruses cause disease in humans. And when we talk about Influenza A viruses, we talk about them based on subtypes. So this is based, pretty much all viruses are a ball with spikes on the surface, and you can see that in the picture below. The spikes of influenza virus are called the hemagglutinin and the neuraminidase, and this is how we classify different types of or subtypes of Influenza A viruses. So we've got the AH1N1 and the AH3N2, and these currently circulate in humans and cause seasonal epidemics. And what we do hear of quite a bit in the media is the very occasional infections of humans with avian viruses of different subtypes, such as H5N1. But one of the really key differences here is that these viruses have not been reported to spread efficiently human to human. So they differ from seasonal influenza viruses in that way. In addition, we also have Influenza B viruses that are associated with seasonal influenza, and these are classified, into lineages. And this is just based on the hemagglutinin spike that they bear. And the most important one is the B, the wrong way around. The most important one is the B Victoria lineage, as this is the virus that circulates currently in humans. And the B Yamagata lineage, the last human case of this was reported in 2020. So when we look at seasonal influenza viruses, this is from one of WHO's global reporting platforms, and we're looking at the number of influenza confirmed laboratory cases And we're starting back in 2019 and looking through to today. And what you'll see is we have these really pronounced peaks of seasonal influenza virus activity. And this is associated with the winters in Australia. Down the bottom of the slide, we highlight the classification of those influenza viruses. The blues relate to the different influenza A viruses, and the browns relate to the different influenza B that I've referred to, noting that we only really see the B Victoria lineage as of the last 5 years. So for comparison, I've included Japan here. And again, you can see they have really distinct cycles of influenza activity. But what I'd highlight here is when we have the peak of our activity in Australia, there are very few cases in the Northern Hemisphere in countries such as Japan. Conversely, when there's a lot of influenza activity in Japan, there is very little influenza activity in Australia. So we see really distinct patterns in the Northern and Southern Hemispheres of seasonal influenza virus. But what I'd just highlight here, and we'll talk a little bit more about, you can see that coming into the start of this year, so the summer in Australia, coming into autumn, we've actually got increased levels of influenza activity in Australia, which sort of correlates with increased activity in the Northern Hemisphere as well. Here's those patterns for Australia and Japan, but just focusing on the 2024, 1st of January onwards. And what you'll see is other countries, such as South Africa and Argentina, show a pretty similar pattern to Australia. Can change a little bit when the season starts. And countries in the Northern Hemisphere, such as the United Kingdom and China, also show a pretty similar pattern to Japan, again, with some differences in the types of viruses or the subtypes circulating, but also when the season begins. So one thing that captured a bit of attention last year was the seasonal influenza season in the Northern Hemisphere in late 2024, coming into early 2025. And what I'm showing you here is some data from CDC that's looking at hospitalizations in different years that are associated with influenza virus. And what you'll see is in the red, there was quite a striking peak of influenza activity that led to hospitalization in the US in the most recent season, so through December, January, and February. I would note this wasn't seen in all countries in the Northern Hemisphere, but it was a particular feature of the outbreaks that were observed in the US. So what's happening in Australia this year? So here we're looking at the number of lab-confirmed influenza virus over various months of the year. And what we've got here are curves for different seasons. So you'll see that there's a few differences in when the influenza season starts. For example, 2022 started very early, whereas 2017 started quite late. And if we look at the red, we can see that through January, February, March, and April, we've actually been tracking at increased numbers, thousands of increased numbers of lab-confirmed influenza in Australia. If we examine what's happening in each of the jurisdictions, again, we have different influenza viruses associated with seasonal influenza in different colours. But pretty much you can see this kind of increasing trend in most of the jurisdictions since January, with a steady increase being observed. So our collaborating centre is part of a global network called the GISRIS network. And this is to monitor the circulating influenza viruses throughout the world. So it was established in the 1950s, this network, and it's really become a key cornerstone of informing changes in influenza viruses that are relevant to updating influenza vaccines. So a WHO committee meets twice a year to recommend the candidate vaccine viruses for the seasonal influenza vaccines. And now the particular focus is on the A's, the H1N1 and the H3N2s, and the B-Vic lineage of viruses. So we meet in February to discuss the Northern Hemisphere winter, and we meet in September to discuss the Southern Hemisphere winter and to make recommendations about the vaccines for each of those hemispheres. So these recommendations are made 5 to 6 months ahead of vaccine release, and this is to allow manufacturers the time to ramp up their production of influenza vaccines. And what's important to note is when we're considering the current Southern Hemisphere vaccine, which is relevant to Australia now, is we had to change and update one component of the vaccine from last year, the H3N2, with the aim of adding a more contemporary vaccine candidate virus to induce better protection to the most recent circulating H3N2 viruses. The H3N2 component is kind of the problem child of the influenza vaccines. It's the one that needs updating the most to keep up with the mutations that occur in the virus as it circulates around the world. Another really important thing that happens at these WHO vaccine consultations is we look at data from avian and mammalian influenza viruses that are circulating and that have caused occasional infections in humans. And we discuss these to work out if we need to prepare or generate any new candidate vaccine viruses as a backup, I guess, for pandemic preparedness. And so, for example, in 2024, we had the first human case of H5N1 was recorded in Australia in a returned traveller from India. So that virus was detected and characterised here at our collaborating centre. And from the most recent WHO vaccine meeting, it's been decided that we need to prepare a candidate vaccine virus for that particular clade of H5N1 going forward, just so we have that up our sleeve if there was any further evidence of human infections in the future. So what other viruses are currently of concern? So there's a number of avian influenza viruses that cause human infections. For example, this very complicated clade 2.3.4.4b, long name, but it's been a really surprising virus. In the last few years, it's spread through wild birds and poultry worldwide, with many spillover infections into mammals. And this is really unusual, and sort of mammals are kind of on the way to infecting humans, you know. And one of the surprising things, again, was a very big outbreak, over 1,000 sort of herds in 17 states in the US, that has affected dairy cows, where it's actually the virus is secreted into the milk. So the poultry and livestock infections in the US have been associated with spillovers into humans. And so at the moment, there has been 70 recorded human cases in the US, one death, but no evidence of person-to-person spread, which is really important. What I'd also highlight is that other H5 clades have been associated with human infections in 2025, and that other avian viruses with different hemagglutinin and neuraminidase spikes, such as H9N2 and H10N3, have also been associated with human infections in particular countries around the world. So the take-home message, I guess, from my first talk is that some countries in the Northern Hemisphere had a severe 2024-2025 influenza season, for example, the US, although others, for example, China, did not. In Australia, we've seen increased influenza activity in all jurisdictions in early 2025 when compared to previous years. Despite the increased influenza activity, we can't currently predict the severity of the upcoming season in Australia. This will be dependent on a range of factors, which virus subtype becomes dominant or which strain becomes dominant, for example. Influenza vaccines are now available and are the best way to reduce the likelihood of hospitalisation and GP visits associated with influenza infections. And finally, some avian viruses continue to cause occasional infections in humans, but there is no evidence of human-to-human spread. And these viruses are being closely monitored by many agencies, including WHO, around the world. Okay, with that, I'd say thank you for your time and listening, and I'll hand over to the next speaker. Thank you.
Thanks very much, Patrick. So we will now hand over to Paul Griffin, who's going to give us a bit of a clinical insight. Over to you, Paul.
Great. Thank you very much, and thanks, Patrick, for going through all that. I'll just get my slides up. Hopefully, everybody can see them. So, yeah, thanks very much for the invitation to join what I think is a really important meeting today. Just some disclosures that have already been disclosed, and we've already heard, obviously, the numbers, big numbers last year, and some big numbers already this year. But what I'm going to speak about is why that's potentially such a problem and what we're going to ask people to do about it. So, we know that we talk about the numbers of cases quite often, but influenza actually causes quite a few significant issues with those numbers. So we know that there's deaths in the order of thousands, hospitalizations around 20,000 every year, hundreds of thousands of doctors' visits, and quite a lot of financial implications in terms of lost work days. So while a lot of people underestimate the flu at the moment, the impact is very significant. And most people will know what sort of symptoms the flu gives. So it can be those respiratory symptoms, muscle and joint pain, extreme tiredness, headache, sore throat, etc. A lot of people mistake other infections for the flu, but the flu is a very significant infection and gives quite a few symptoms, even if people don't go on to get what's classified as severe disease. In children, can also cause some gastrointestinal symptoms. So the thing there is, of course, those symptoms are all non-specific. So you can't tell when someone has the flu necessarily based on some of those. So we do recommend people get tested so they know what they have. As you can see here, just some figures on how easily spread it can be. Can survive on surfaces for a long time, in the air for quite a long time, and even for a relatively long time on hands, which again is why some of those basic hygiene principles are what we recommend to control the spread. Can be infectious for quite a long time. So even before symptoms appear potentially, and then even for up to a week thereafter. So it can be quite easy to transmit, which is why we recommend some steps to limit that. And it's very clear that children contribute very much to the spread, both because they potentially shed more virus, but also because it's a bit harder to get them to do the hygiene things that we ask of them. We hear this a lot, it's just a flu, but it's not just a flu. It's a very severe viral infection in its own right and can be life-threatening. And we know a lot of traditional risk factors. We target those people for vaccination, other interventions, but severe disease doesn't occur exclusively in those groups. So even people who are well without medical problems can progress to more severe disease. And I've listed those people who are highest risk there. It's the young, older adults, people who are pregnant, importantly, people with chronic medical conditions, Aboriginal and Torres Strait Islanders, and smokers also are at higher risk. And in the bottom right, you can see what the flu can do to a healthy child. This is a child diagnosed with influenza in the United States who needed support to breathe and a lot of other interventions to survive that infection. And I've listed some of the severe manifestations there, a lot of very significant lung problems, including secondary bacterial pneumonia, heart problems like myocarditis, can cause brain issues, blood issues, a whole host of other things. So, once again, not just a flu, very significant in its own right. And if we just look at the impact by way of admissions here, you can see in the last reporting period, here's the Australian Respiratory Surveillance Report, nearly 130 admissions in that last sort of 2-week period or thereabouts. And you can see there's been quite a few people admitted this year with the spread by age depicted there. It's a pretty even spread there at the moment. The axes obviously are a little bit different, but quite a few people in those older groups. But you can see there are people in some of these I guess, very young or very old groups that have also required admission to hospital for supportive care because of their influenza infection. And we do unfortunately see people not survive this infection. So a bit of a lag in robust data from this year, but in January, 26 people had a death that was attributed to influenza infection and around 1,000 associated with influenza last year. So, once again, an important metric that indicates how significant this infection can be and why we want to encourage people to take steps to reduce that risk. So we often get asked, what do we want people to do? And I guess there's things we want people to do before they get infected. The best way of addressing any infection is to not get infected in the first place. Vaccination, I've got that in bold there, and we'll hear a lot about that during this presentation, of course. We want people to take steps to reduce their risk of getting infected. I mentioned can survive on surfaces and survive on hands. So hand hygiene, basic hygiene, very important. We've heard a lot, thanks to COVID, about air quality, ventilation, etc., and that plays a very significant role with other viruses, including influenza, and even mask wearing. While not as popular now as it once was during COVID, masks certainly help with this infection as well. And if people have medical problems, particularly those that impact their risk, obviously making sure they're well controlled ahead of time is important. But if people do get symptoms, even if they don't know it's influenza, and these are things that we had people doing at very high rates early on in COVID, but I think, and no data to back this up, that we're probably doing some of these basic things at the lowest levels we've done for a very long time. We asked people to do these things each and every flu season before COVID. We did these things well during COVID, and I'm not seeing a lot of that at the moment. So staying home wherever possible. If you have symptoms of any respiratory infection, cough and sneeze etiquette to prevent those particles that I showed a very quick picture of spreading to other people, basic hygiene, and once again, that focus on air quality or ventilation, and masks may have a role. But we want people to manage this as well, and that's where testing can be very important. I highlighted some of those symptoms, and we know you can't tell these infections apart, so getting a test so we know what people have. We have antivirals for COVID and flu. We have antibiotics for things that can look similar, like mycoplasma or whooping cough, so that's important. And getting medical attention, of course, if you're high risk or particularly unwell. A lot of myths about vaccination, so I thought I'd just quickly cover some. A lot of people say that they got the flu from the vaccine. We know that can't happen, no live virus. People can get all sorts of symptoms around the time of vaccination. Some of those might just be from their immune response to the vaccine, which I like to sometimes tell people that's just a little indicator that the vaccine's potentially working. Doesn't correlate with protection, but a useful thing to let people know that it's their immune system kicking in. They might be infected with another virus, and I'll very quickly show there's a few other things around. And they may even get the flu shortly after their vaccine by sheer coincidence, because we know you don't get maximum protection immediately after receiving the vaccine. We hear people say, and it's particularly relevant when we have a high start to the season, as we see now, that I've had the flu, so I don't need the vaccine. But as we've heard, there's a number of components, and you can get more than one flu in any given season. We hear people say they got the flu in a year they were vaccinated, so what's the point? So we know it doesn't stop 100% of infections. That's why we recommend some of those other complementary interventions, but it goes a very long way to reducing the severity and maybe the duration as well. We hear people say the vaccine doesn't last a long time, but we know we need to get protection every year, and we roll out our vaccines so we get that good protection in anticipation of the peak, and now is definitely the right time. As I mentioned, we hear people say, well, I'm young and fit, I don't have all those medical problems, I don't need it. But as I've highlighted, even people without high risk conditions can get severe flu. And we hear people say that they're not sure they can get vaccines together. We know that a lot of the respiratory pathogen vaccines, like we're talking about with flu and COVID and RSV, you can get at the same time. And I just thought I'd quickly touch on some other viruses. So here's the case numbers for COVID, flu and RSV. And you can see a relatively significant increase in RSV recently. The axes, once again, are a little bit different, and a decline in COVID at the moment, which is useful, but of course not going to continue forever. Just to very quickly, a very busy slide, highlight some important figures by number. You can see in terms of COVID, still quite a few cases year to date in that older adult group where the impact's greater. We see with influenza quite a lot of cases highlighted in red in younger children, and that big number of total cases at the bottom. And you can see there with RSV, a disease of young children as well as older adults, lots of cases in children there. So quite a bit of these things around. And just to sort of show what people are testing for if they have an influenza-like illness, you can see a bit of a mixture here, a bit of rhinovirus, parainfluenza, quite a bit of influenza as well, a bit of human metapneumovirus, but also a bit of mycoplasma and pertussis, fortunately not in high numbers, but again, highlighting the importance of testing, because we can say which of these pathogens someone has and recommend specific intervention. And just by way of indicator of severity, admissions with these viruses at the moment, you can see quite a few with influenza in blue, green is RSV, and quite a few admissions for RSV, unfortunately low levels of COVID at the moment. But we know that it's a matter of time, can't predict when, but we know there'll be an increase in COVID again at some point. So just to wrap all that up, I know I went through quite a few things quite quickly. Flu is hard, doesn't necessarily tell us what this season's going to bring, but should serve to highlight the importance of measures to reduce that risk. Flu is a very significant pathogen, so again, should more than justify taking steps to reduce that risk. We have a lot of highly effective interventions to do that, vaccination, of course, but also ways of reducing your risk of getting the flu and managing it well if you do have it, particularly antiviral medicines. And there are other pathogens circulating, and that does compound the challenges we face from the flu each and every year. We know we have a healthcare system that's under a fair bit of pressure at baseline, and so having more than one thing circulating at any one time does increase those challenges, and that's why we want people to take steps to reduce the risk of all of these viral pathogens this winter. Thank you.
Thank you, Paul. And finally, we will hand over to Professor Julie Leask. Over to you, Julie.
Thanks very much, Lyndall. And just get this going. And I'm just swapping the display. Lyndall, is that?
Yes, that's perfect.
Great. Okay, yeah, thanks. And nice to see some familiar names here. Welcome, everybody. And I'm speaking to you from Gadigal country. So I'm going to share some insights on the factors associated with flu vaccination. So this is more the social side of vaccination. And these findings come from the National Vaccination Insights Project, which is a collaboration with the National Centre for Immunisation Research and Surveillance, the Murdoch Children's Research Institute, and our team at the University of Sydney, which is called Social and Behavioural Insights in Immunisation. And I really want to acknowledge my colleagues here who are part of the dream team that are doing this work. So, just to summarise what we've heard so far and what we'll hear in a moment, our flu vaccination coverage is perpetually low. And I'll show you some of that data in a moment. But some people are being hospitalised or even dying from a disease that's potentially preventable. The vaccine isn't perfect, but it's much better than zero, which is what you're looking at if you don't have a vaccine. Of course, there are other measures to reduce the risk of respiratory infections, but nothing matches an effectiveness of even between 50 and 70%, and even better in children having that vaccine. So it's really important to understand why people don't vaccinate. We can't keep second guessing the public and imagining why they're not vaccinating. We've got to ask them, and that'll help us fine tune the best solutions to this problem. And here's the problem. So for the black line you see here, and this is from 2020 to 2024, these are the 65-year and older age group national data from the National Centre for Immunisation Research, showing 62% of people had a flu vaccine by the end of the flu season in 2024, and that had declined since 2022. For children, that's another important group. So that's the 6-month to 5-year-olds who are also have the vaccine recommended and it is free for them. That group have a coverage rate of 28%. So our influenza vaccination rates in Australia are dire and they're not improving. So just to quickly show you what we're doing this year so far, 2025 is the line in the red compared with the last 5 years. And you can see that our flu vaccination rates are tracking 32.5% of 65-year and older people have had a flu vaccine. So we're not really doing better than the last few years in terms of how we're tracking so far, which is why what you're doing in reporting this issue is so important. And the lady on the left is my mum a few years ago, a healthy person who continues to have her flu vaccine. So our project is looking at the drivers and barriers of vaccination, and I'm going to focus on the influenza vaccination adults survey findings from 2024 and 2025, where we surveyed just over 2,000 adults at each time. So the data that you'll see today particularly features 2025, where we collected that in March. This is a national survey or attempting to represent the entire population of people 18 years and over, never perfectly representing them, but we do our best. And this is what we're measuring. This is the behavioural and social drivers of vaccination framework. And we're particularly interested in intention to get recommended vaccines. And we ask people, do you want an influenza vaccine in the upcoming flu season? So that's what we asked them this March when we did this survey. We also ask about how they think and feel about vaccines, social influences, and those all-important practical issues. So in our sample, the number of vaccines people reported having in the last 2 years. In 2025, 49.5% had had 2, 18.5% had had 1, and 32% had had none. When you look at whether people wanted to have an influenza vaccine in the next season, more people said yes. Some were not sure, I'd say they were hesitant, and some were planning to not. And those numbers are not that different year on year. What about the trends in terms of the location of the flu vaccine? Most people are getting it from their doctor's office, followed by the pharmacy. Workplace is a really important avenue of protection, particularly for pregnant people. And we then ask people what makes it hard to get an influenza vaccine. And the different factors there, the biggest one each year has been costed, being expensive for that person, whether that be the vaccine itself or the appointment, making an appointment itself, inconvenient opening times, cannot take time away from work, long wait times, hard to get a vaccination place to the vaccination place, particularly an issue for people in rural and regional areas, and the vaccine was not available. Well, now, what about how people think and feel? So 78% said that they think the vaccine is safe. That means that 22% don't think it's safe. And that's a pretty perennial issue with the flu vaccine, unfortunately. Some people hold some of those myths that Paul was mentioning. What I'll do is just highlight the ones with the purple boxes around them because they're significantly associated with wanting to get a vaccine. So they're particularly important. Safety, perceptions of safety, the vaccine being important for my own health, 60% said it was important. But not a lot of people are very or moderately concerned about getting influenza. And for some groups, there kind of should be, because influenza can be very severe for them. It can really knock them out. For social influence is incredibly important when it comes to vaccination. Most people are the main decision maker, but some people are not, and they have someone else making that decision for them, particularly younger people or older people, people with a disability. So it's important to be targeting them in terms of encouraging them to facilitate vaccination for their loved one. Just featuring here, I feel responsibility to get a flu vaccine. That was associated with wanting one. That shows that the sense of altruism, of looking after others, is important for people. And that's kind of a hit when you think about campaigns. Community leaders want me to get a flu vaccine. We call that in psychology an injunctive norm. It's a norm where we think about what others who influence us want us to do. And religious leaders, for those who have a religious leader, that was also associated with wanting to have a flu vaccine. And finally, practical issues. Most people know where to get the vaccine. For most people, it's very or moderately easy to get one. There's, a significant proportion who still would find it difficult to pay for the vaccine. And then I've been contacted about getting a flu vaccine in the last 12 months. That's where you see an area for improvement, because recommendations and reminders work. We know this. Only 18% said they had been contacted about getting a flu vaccine in the last 12 months. So just to summarise, there's a lack of concern about influenza. It's the kind of underdog of infectious diseases, and people tend to underestimate its severity. It's particularly severe in children and older adults and people with comorbidities, i.e. they're at risk of severe flu because they have another chronic condition. There's the perceived safety and benefit of the vaccination contribute to people getting vaccinated. What I also showed you earlier with one of these earlier slides is that bold text at the bottom, where we looked at the odds of wanting a flu vaccine. You're much more likely to want one if you'd had one previously. In fact, you are 9 times more likely to want a vaccine in the coming year if you'd had at least one in the past 2 years. And we know that flu vaccination is a habit. And once you start that habit, you tend to continue with it. So initiating the habit for some people is particularly important. And who can do that best? Healthcare workers. They're influential, and not getting a vaccine is often associated with a healthcare worker not recommending the vaccine, as we've seen in other studies that we've done, particularly around children. Cost and inconvenience are barriers, and influenza vaccination is a social practice. The images on the right are some of the current IT campaign reminders from New South Wales Health. They're trying a slightly different angle this year, focusing on the benefit of potential benefit of getting a flu vaccine, and I am missing out on getting influenza. And they're really trying to grab people's attention because I think in many ways the campaigns it's been really challenging to get people to take up vaccines, and governments continue to try different ways to do that through their campaign messages. So one of the things we need is better data on certain groups. You've seen some data from the register, but having better data on who's vaccinated among pregnant populations and among those with comorbidities will be helpful to see how we're tracking nationally with those at-risk groups who are recommended and can have a free flu vaccine. And we need to keep busting those myths, such as that flu vaccine gives you the flu. It doesn't. Campaigns need to remind people of the benefits to self and others if we get a vaccine. We might not think we're at risk, but we may help protect other people who are. And the flu vaccine is a bit better than the COVID vaccine at doing that. So these are different vaccines. Campaigns, people need SMS reminders, they work, or any kind of reminder. Convenient access is important. Antenatal clinics, hospitals, pharmacies, Aboriginal medical services. Workplaces can be more proactive in encouraging and offering vaccination, and healthcare workers need to remind people when they attend for another reason. We call this opportunistic vaccination. So I'll end it there and send it back to you, Lyndall. Thank you.